Thank you all for coming. It's wonderful for me to be back here. This is one of my favorite places, and Hannah, welcome.
Thank you so much.
I wrote a book on polio about 15 years ago, and I've read a lot about it since through other works. And I think what really struck me, and I will call you Hannah, if I may,
Absolutely.
about Hannah's work. I was asked to review it by JAMA, the Journal of the American Medical Association. And it had the title The Autumn Ghost, and polio, as we know it, was a summer disease. And it really struck me that there must be something new and important about this particular work. And the deeper I got into it, the more that question was answered. This was really a very, very unique perspective on not only polio, but major issues surrounding it, particularly how you dealt with polio patients. We had always taught our students about the iron lung. I had always thought the iron lung was godly. I read Hannah's book and found a very, very different perspective on it. And I thought what was really unusual was that every chapter has something I didn't know. And that is unusual when you've been spending a lot of your time working on this particular disease and on infectious disease in a general sense. So what I'm hoping tonight is that Hannah will help us flesh out what is really important about her book, what is new about her book, what we hadn't known before, and then with the audience, maybe get into a general discussion of infectious disease today. As you know, it's become front and center again with measles, whooping cough, and other diseases. So Hannah, I give the floor to you for the moment.
Well, thank you. I appreciate that introduction. And I do just want to pause and really thank the New York Society Library for this opportunity to speak to all of you tonight. To Dr. Oshinsky, David, for willingness to come out and engage on a topic that I know wrote about quite a while ago, and so to re-engage on, and also to thank Greystone Books that published this book, which was on a topic that was considered a bit obscure, I think, at the time, and we can get into that around the issue of books about polio, and also the corner bookstore that is here tonight to sell books. And what is nice is it is the release of the paperback of this book this week. And I think there was a lot of question as to whether or not another book after yours that was about polio, could engage people. And you spoke to the fact that I had a different take on the issue of polio, and I think that speaks to the fact that I'm a critical care physician by background, and I worked in the ICU, and really I came to polio not initially because I was interested and excited to read and write about polio, but because there was this kind of one key event that was actually crucial for my specialty that happened to be a polio epidemic that it took place in. And so, I know many of you in the room have actually read the book, but just kind of very briefly for anyone who hasn't, just to give a very quick description, it centers on a polio epidemic in 1952 in Copenhagen. And it's the story of this one epidemic because that is the moment that we went from having iron lungs, which were already referenced, which was what's called negative pressure ventilation, that sort of sucks the lungs open, and was very successful in certain forms of paralysis from polio, specifically when people struggled to breathe because the muscles of their chest wall were paralyzed. But it was very unsuccessful for caring for patients with what was called bulbar polio, when it hit the brainstem, caused people to have difficulty swallowing, coughing, and there was a 90% mortality still with polio in those patients. And in this particular epidemic, they were hit with a lot of patients with bulbar polio. And being at their wits' end, they end up turning to a young anesthesiologist, and there's a lot of coincidences and parts of the story we can talk about later as to how he ends up there. And he proposes something that sort of from the modern perspective sounds so obvious, but at the time really wasn't thought of, which was what was called positive pressure ventilation, blowing air into the lungs to keep people alive, and recognizing that it was literally just the lack of the ability to breathe that these patients and keep the secretions out of their lungs that was keeping them, that was causing them to die. So that moment and the kind of invention of positive pressure ventilation and what we now think of as mechanical ventilation, that of course became front and center in COVID, although it was always there. I mean, that was the thing. It was always there in the background in the last 70 years in ICUs around the world. But it is this pivotal moment. And because they didn't yet have ventilators, they realized they needed to do this. And they called on the medical students of Copenhagen who sat at the bedside and hand ventilated these patients 24 hours a day, 7 days a week, 4 months. And at one point they had 70 patients ventilated this way at one time. And they ended up saving, estimated well over 100 lives, probably much more. But more importantly, even than saving those lives in that specific epidemic, was this moment that they realized that this was the way forward to care for polio patients, and then anyone and everyone else who was critically ill. So it was really interesting to come at this story from the perspective of taking care of patients on modern ventilators and looking at it backwards through this lens of, kind of how could we have had this period of time, people in the room that lived through before they even existed. I would be using them every day to care for patients. And so it was really that lens that I was starting with. And then I thought, oh, I need to learn about polio to tell this story, and realize that in medical school, they didn't teach about polio, and I knew nothing about it. And that was a real wake-up call to realize that this disease that was considered pretty much dead, and I'm sure we'll get into, into that, was something that I needed to learn about. And to sort of fast forward, someone just told me that Columbia has reintroduced polio into its medical school curriculum. Yeah.
Because the Smithsonian, I'd say about 25 years ago, had a major exhibit called "Whatever Happened to Polio." We've had one case in the United States in the past 30 or 40 years, and it was a case of an unvaccinated person who came in contact with someone who had been out of the country and brought the polio virus with them. What is interesting about polio is that in epidemic form, it's largely a disease of the 20th century and a disease of the West. And we really don't know why, even to this day. Some people feel that it's a disease of cleanliness. In other words, the more antiseptic society became in these years, the more likely kids were not going to be exposed to it at a young age, when they would have maternal antibodies and the disease itself was less virulent. We really don't know. What also struck me is we know it's a summer disease. I mean, I look around right now at the audience. There are some of you my age, and I think you can remember what life was like before the Salk and Sabin vaccines. In New York City, where I grew up, it would be like in June, the various newspapers would have box scores of the number of kids entering polio wards in New York City. And the numbers would start to rise in June, go higher in July, go very high in August, and then it would sort of crash after Labor Day as fall came. And that's why the autumn ghost fascinated me so much. And I'd go back to school, one of the things polio, as Hannah knows, in terms of other major childhood diseases, did not have that many victims. It simply did not. But it's because it's the disease of children, and because there was no prevention and no cure, parents were absolutely panicked by this particular disease. And I can remember as a boy, having a polio test every week. My mother would, could I, touch my chin to my chest? Could I touch my toes? And any, the slightest stiffness would send a panic through the people. Polio was like that. And until the vaccines came, it really was America's disease. What I find interesting, and Hannah, we can talk about this, in the United States, you had Franklin Roosevelt, you had the March of Dimes. The government did not get involved in this at all. This was all done with private money. Salk and Sabin were both basically given money by the March of Dimes. When you go over to, and there were plenty of respirators, nurses, doctors. There was a huge facility in Warm Springs, Georgia, that took care of these people. You go over and you talk about medical students. And here was a country, a very, very small country, but a Western country that had this was really a frightening period for them. But maybe you could also talk about sort of the role of government there as opposed to the role of government here, where, there was virtually no NIH at this time. There was, I don't even want to talk about what's going to happen next month, but it was a very different situation. This was the people's disease, and it was all done through private contributions. And we look at something that happened, an epidemic in Europe, and you see a very, very different story.
Yeah, no, it is, and the difference is actually in cultures, in government, and all of that is really striking. And you allude to, the title of my book, The Autumn Ghost, and for anyone who hasn't read it, it has that title because in the Scandinavian countries, it tended to peak in the autumn. So this epidemic I was writing about starts in July, which is early for them, and they start to see this trickle of cases, and it's building, and by mid-August, they're seeing 50 cases a day coming into this one hospital in the center of Copenhagen. And because it's this autumnal disease, they know they're not even near the peak. And so we still don't fully, to your point, a lot of the research stopped on polio in the 1950s when the vaccine came in. We still don't fully understand how and why that was the case, and why it was different there than it was in the United States. But to get to your point about sort of what they had available to them was one iron lung. So the United States was sort of overflowing with iron lungs at the time. And what's interesting is that they understood that having more iron lungs in this case actually wasn't going to help. They couldn't articulate why. And it's always interesting to try to go back into people's minds 70 years ago and sort of kind of things that feel so obvious that weren't obvious to them, but they knew that much. And they knew that, asking the government to buy more iron lungs was not the answer. But what is interesting is to sort of look at this moment of innovation and to kind of dissect what were the components that are useful to us to think about, but also just kind of what did it take? And there's a lot of coincidences of sort of people, right place, the right time. There is desperation, which is something I think we try not to mimic if we can possibly help it, but often is the case. And they also had the ability to experiment, so there's not a lot of government regulation of anything, either there or here. And that, in the moment was very useful for them. And they could just sort of try this new technique out on one 12-year-old child named Vivi Ebert, and they were not asking her mother for permission. There was no government swooping in saying, you can't do that. But then I think an important piece is once they realized that this was going to work and they wanted to do it with everybody, it did take an enormous amount of resources. And ultimately, they paid the medical students to be doing this. And the government did step in and basically gave them carte blanche and said, spend what you need to spend to make this happen. And so that was an important piece of the innovation, was that they were kind of allowed to because they had the financial backing. There are some other pieces to the innovation that, I think are relevant to thinking about today. One is, I mentioned this with young anesthesiologist, his name is Bjorn Ibsen, is the one who comes in. Anesthesia as a specialty existed for 1 year before this. It was, before that, it was the Wild West. It was med students, the nurse, the surgeon, secretary, anyone could give anesthesia. Really terrifying. And so he was very young and in many ways inexperienced, but actually his not knowing about polio and not having this sort of received wisdom that had been taught to everyone that, oh, the virus overwhelms the body and there's nothing we can do to reverse it. That was actually pretty crucial. And so I sort of make the point that in today's climate in particular, to think about the fact that the sort of alternative perspective diversity of who's part of your group trying to solve problems is actually really, really important. But then the final piece, and you referred to this when you mentioned Warm Springs, the fact that there was a lot of money to support rehab in the United States for these individuals, and that they didn't initially have that in place in Denmark. But again, it's a very nice system where they care about supporting each other, and they very quickly emulated what was being done in the United States to provide rehabilitation and support. And one of the things, of course, that comes out of polio is a lot of the understanding of rehabilitation medicine,
Right.
Because of the need to provide this support to individuals.
Yeah. Hannah, I was wondering if you could also talk about the fact that with Ibsen, there was real skepticism in Denmark. And there was kind of a pecking order. There was one wonderful part in your book where the few anesthesiologists would be riding their bikes home with the smoke from the automobiles of surgeons, making them cough and things like that. But what was interesting is that Ibsen basically had to come to the United States to be fully educated about infectious disease.
Yeah, actually, just to be fully educated about anesthesiology,
Yeah.
he didn't actually know about infectious disease very well.
Yeah.
And yeah, so that was interesting because anesthesia didn't exist as a specialty. He was told, if you want to learn about this specialty and he was interested in doing it, you've got to go to the UK and United States, where anesthesia was a little bit more established. But what is interesting about his time in the United States is, and he wrote about it a lot later, was that it wasn't just that he, learned this new specialty he was interested in. He really felt it was a different environment, a different culture. He felt it opened up different ways of thinking about things and sort of not taking for granted the received wisdom on things, that he felt freer to speak. He really felt Denmark was much more hierarchical in terms of its medical system, which I always find kind of remarkable, because if you want to talk about hierarchy in medicine, I always think Harvard in the 1950s or 40s is probably up there. But I think that really then gives you a sense of, if that was free and kind of open feeling to him, what must it really have been like in Denmark? And the man who was in charge of the hospital, Henry Lassen, was very imperious, very senior, kind of 15, 20 years older. And at one point, Ibsen in an interview said, he was like God. These heads of the hospital were professors at the university. And to go up against that and give your ideas, there are not many doctors who would have had the spine, essentially, to stand his ground and propose a novel intervention to care for a type of patient, a polio patient that he'd never cared for in his life. And so I always, when I speak to medical schools and talk about the book, one of the things I always say is to the trainees in the audience, get out of the United States and see medicine somewhere else. Even if it's just for a day, rounding, on a ward in a hospital in Denmark, Canada, it's just somewhere else. And unfortunately, our training is very, very narrow in its focus, and really makes it hard for people to step off and spend time elsewhere. And so I do really urge people when I talk to them about the book for that reason.
Yeah. Just about when your hero came to Boston and to Harvard, there was a man, John Enders, who was working there. And John Enders was the man who, among other things, realized that it was possible to grow viruses in vitro, and therefore this, dramatically speeded up polio and all kinds of responses to polio and all kinds of other diseases. What is interesting about Enders, he was not a doctor, he was not a physician. He was a PhD, came from a very, very wealthy family. And he was working on what turned out to be a Nobel Prize winning project. And Harvard gave him a certain amount of money for the project. And he said, this is wonderful. And then the March of Dimes gave him extra money. And Harvard made Enders turn down the March of Dimes money. And Anders said, why are you doing this? And Harvard said, well, it's very nice that they gave you $75,000, but who's going to pay to heat your lab? Who's going to pay for the monkeys you're using up endlessly? We just don't have the money. And it was the March of Dimes that basically thought up indirect costs. Indirect costs are now almost at the center of the battle of what's going on with the NIH and the current administration. And the reason I bring this up is it's so important to understand what goes in to a laboratory, what goes into a discovery, and the fact that it took an organization like this to kind of figure out a way to make it work. And I think that somehow in going to Boston, Ibsen was exposed to all kinds of things that were happening in the better labs in the United States, but not elsewhere.
Yeah, his sense of kind of the excitement and just broad thinking going on. And just as a side anecdote, my next door neighbor on Cape Cod actually was invented the H flu vaccine and worked with Dr. Enders briefly, and he described how Enders was always the first one to roll up his arm to take a jab to test out a new vaccine, and that he was very sort of encouraging and keen on being part of the experimentation. And a lot of actually to sort of say in passing that everyone who was involved with vaccine development, that was a thing that you had to test it out on yourself.
It was who goes
yeah.
first.
Yeah,
That
exactly.
was the phrase.
But Ibsen, Ibsen clearly his brain was formed by that year in Boston in a way, and that goes to the point that I was making. There's a lot of coincidences of just they tapped the right person who'd had this unusual exposure at this right time. He also happened to be working in the operating room on a study looking at exhalation of carbon dioxide. And this was a key kind of point, which was that 70 years ago, one of the doctors at the Blydam Hospital in Copenhagen said, we just didn't think about carbon dioxide, the fact that you breathe in oxygen, but you also have to breathe out carbon dioxide. And that if you're not breathing well, the carbon dioxide builds up. And so Ibsen just looked at these polio patients, said, they're dying from too much carbon dioxide in their body. They can't exhale it. And the fact that they picked this one man who happened to be working on that topic and was thinking about it is really one of those, remarkable things that unfortunately you can't engineer. That's the part of innovation that it's very hard to control.
The other thing, I'll just mention this in passing about Enders. He was the only polio researcher to win a Nobel Prize. Jonas Salk never won one. Albert Sabin never won one. Jonas Salk was sort of by far the most popular figure. He was kind of the white knight who came out and was put by the March of Dimes in front of the cameras. Actually, Salk was once asked whether he felt bad that he hadn't won the Nobel Prize. And he said, I don't feel that bad because most people think I did win the Nobel Prize. So, but in the case of John Enders, when he won the Nobel, it was almost a demand that two young researchers in his laboratory, Robbins and Weller, share the prize with him. And that was, trust me, given the history of the Nobel Prize and the throat cutting that goes on, this was really, really, really remarkable. So I think when we remember, sort of the people who really push the envelope, we tend to think of the Salks and the Sabins, but there are people like the Ibsens and the Enders who are in there as well.
Yeah. Well, I mean, you've been referring a lot to the importance of the vaccine. And when I was writing this book, the very first draft I wrote, I gave to a friend who used to be an editor, and I forced her to put her editor's hat back on for me and read it. And she came back to it and she said, polio needs to be more of a character in your book. That you need to write this book where it's clear that that's the enemy that they're fighting, and really to make that distinction that really what they want to do is just get rid of polio, right? And that and the innovation that I end up writing about is because they haven't yet, right? They're a few years on the cusp of reaching that vaccine, and all of that work is going on in the US and actually in Denmark as well. They were doing a lot of collaboration. But you know, it's been really interesting to sort of, when I started writing this, took for granted that the fact that the vaccine was out there and had been since 1955, and that I was writing about, you know, something that we were never going to see again of an epidemic like this. And so it has been really sobering to watch, even from the time I started writing this to now, the change in the conversation around all of this.
We'll talk about that in a bit. There really has been a change. And the history of polio is fascinating. I mean, you have Jonas Salk, who has what's called a killed virus vaccine. And he has the largest experiment in American history, the largest medical experiment in American history. More than 1 million school children around the country took part in this experiment. They either got 3 shots of the real vaccine or 3 shots of a lookalike placebo. And it was double blind. Neither the person getting the shot nor the person giving the shot knew which was which. And you try to imagine today, a vaccine comes on the market, no one is certain how well it works or how dangerous it may be, and parents are pushing their kids into line. It's unbelievable because they understood risk versus reward. They saw polio every day. They saw the leg braces. They saw the iron lungs. They understood the danger. And for them, the vaccine, the experiment in and of itself was a blessing. My mother was a very tribal woman. I remember her so fondly, but her view of the polio vaccine was Salk's Jewish, we're Jewish, how bad can it be? There I was in line. So, you know, that happened. And then you have Albert Sabin, who was working on the live virus vaccine, which he believes and the scientific community believes is a better vaccine. So Sabin cannot test it in the United States because so many kids have already gotten the Salk vaccine. So Sabin has to go to the Soviet Union in the middle of the Cold War to test his vaccine. And this is no double-blind test. 70 million kids are lined up throughout Eastern Europe and the Soviet Union and given this, you know, sort of the sugar cube, the oral test. It's unbelievable. And Sabin loves it over there. He keeps saying, my God, you know, you tell these people to come at 9 o'clock in a straight line and there they are. Well, Stalin probably had something to do with that. Can't say for sure. But every step of the way, there's just an amazing story about how all of this comes together. And as Hannah mentioned, once the vaccines are seen as successful, research largely ends. You know, why, you know, why do we need to do any more research on polio? But as Hannah also knows, there were hundreds of thousands of kids who have been paralyzed. And in terms of research, they were largely forgotten. And even the March of Dimes, which during the polio era was providing all kinds of help for children who had polio. Once the vaccines came out, they basically reinvented themselves, you know, worked for preemies and making sure that, you know, pregnant women were healthy and the like. So there are people out there who are still alive, polio survivors, and there's been little to no research that has been done in that area.
Yeah, no, I have found that my sort of focus in the book and talking about the book has shifted towards recognizing that a big part of its importance is the fact that it tells the stories of individuals who had polio. And that it's really trying to get people to remember that for the many generations who've grown up without the sort of evidence around them of what happens to people. And in fact, I know we're probably coming towards the end, but I did want to read just a very short excerpt. And what was interesting in preparing for tonight was realizing that I was going to read a different excerpt from what I used to read when talking about this book, because of this shift in emphasis. And that while, of course, the central innovation that I write about is crucial, that more and more I feel like I need to be an advocate for helping people to remember what it was like for these individuals. So I just wanted to share with you a short excerpt, and this is kind of towards the section and chapter called Rehabilitation. And it's about one of the children who had polio in the 1952 epidemic and describing what he went through as he recovered. Dan Foldiger was in the hospital for almost a year. He spent most of each day strapped down in his bed with 20 minutes twice a day for stretching and exercise. The doctors recommended he go to Hornbeck for rehabilitation, but his mother refused. Mrs. Foldiger wanted her son home, and she was determined he would walk again. So she brought him home and embarked on a training program of her own initiative, with Dan doing gymnastics on the living room floor of the small 2-bedroom apartment. While Dan was glad to be home and slowly improved, life after polio was not easy for a little boy. At night, he wore a fixed brace on one leg that meant he had to sleep on his back. When he finally started school, a little late at age 8, he had a brace on each leg, hinged at the knee, a corset to help him sit up, which included an extension up the back and behind the head to support his neck, crutches, and special boots. His school was up a hill and he could not manage to walk there on his own. His mother had to push him in a stroller, a setup that made him a ready target for bullies at school. Then there were the shoes, light brown in color. Dan remembered, the loathing of these special shoes made of thick, sturdy leather was universal. When he returned to school after the summer at age 14, Dan noticed that the girls had changed. They seemed a lot more interesting. He dreamed of dancing with one of them in particular, but knew that this was not possible with his orthopedic boots. He begged for a pair of normal shoes, but his mother said no, telling him it wouldn't be good for him. He took his own money and went down to the shoe shop. He loitered in front until only the owner of the shop was inside, and then he walked in and explained that he wanted a pair of shoes. The shoe salesman looked down at his boots. Not only were they orthopedic, but his feet were different sizes. The man sold him one shoe from 2 different pairs, only charging him the price of a single pair. Dan later learned that the shoe store owner had a son of his own about the same age who had also had polio. So I think that, there's so many stories like that. And when you start talking about polio, it's been amazing to me how many stories surface that people have in their families, amongst friends, that kind of has been buried, right? And one of the things was I discovered a lot of these survivors told me that they were told never to talk about it, that it was very much this attitude of that's in the past, particularly now with the vaccine, that others aren't going to have to deal with this, just move on, move forward. You mentioned that a lot of them are still out there, and a lot of them have what's called post-polio syndrome, which is sort of new onset of symptoms, weakness, fatigue, pain, that can happen anytime about 15 years onward afterwards. And so, in fact, every single person I interviewed for this book had post-polio syndrome.
Right, it's not the return of the virus.
Right.
It's just the muscles have broken down. Over the years.
But people have forgotten because many of them recovered, have died off, or were sort of told not to speak about it.
Yeah. Let me say finally, and it's a beautiful passage. Polio is not gone. It's gone in the West, but there are countries, Afghanistan, Pakistan, Nigeria, where the wild virus is still circulating. Now, we are actually in a kind of battle within the public health community. Only one human disease in history has been wiped off the face of the earth, and that is smallpox. We're this close with polio, but we've been this close for a long time, for at least 2 or 3 decades. And there is actually part of the public health community that believes polio has been contained. And since there are just dozens and hundreds of victims now, not tens of thousands, that we're spending too much money on it. And it's time to move on. We've contained it. We still will try to vaccinate as best we can, but there are so many other diseases with more victims and patients, and we should basically focus on that. My own feeling is that this is a mistake, that we're awfully close. And one of the amazing things about smallpox is that no one has had to have the vaccine for the past 45 or 50 years. Think of the money that we have saved simply by not having to deal with this problem ever again. With polio, we're kind of in the netherworld right now. But what I'm really worried about, and I'm sure Hannah is too, is that if we stop vaccinating, it's only a plane ride away. That's, there's something known as herd immunity. And when we get below that, we're gonna begin to see, if we do, we're gonna begin to see cases of polio in our own country. On that high note, maybe we could take some questions from the audience.
Yes, that'd be great.
I'd like to hand the microphone to.
If you can turn the microphone over to them so we can hear as well.
Yeah,
thank
that's
you.
the idea, yeah. Who's that question?
Hi, so you said that everyone you interviewed had post-polio. I was wondering if you could elaborate on their experience with that, both if there was any government support, but also just how it's handled in the medical community.
Yeah, so it's an important topic because this is really what they're fighting now, right? Having had polio as children, thinking they'd conquered it and gotten back to normal lives, and then here they are, in their 60s, 70s, 80s, struggling again. And so, as an example, one of the women I interviewed was a surgeon. She did recover enough to have a normal function, but she had to retire from operating age 50 because she started to develop just this weakness in her legs and fatigue. And just couldn't physically manage it anymore. And by the time I got to know her and interviewed her, she could still walk unassisted, but only for very short distances, and was sort of making plans. She lived in a home and had moved to a apartment that was all on one floor, knowing that she was probably going to need a wheelchair at some point. And that was very common. People that I interviewed, they all had canes, they were in wheelchairs. In Denmark, they do have remarkable support for these individuals. It is an incredible society. They actually have a polio hospital there that I visited just outside just outside Copenhagen. And they have incredible rehabilitation facilities. And really the goal with the post-polio syndrome patients is maintenance, right? It's not recovery. And it is a little bit like what we're seeing with COVID symptom, long COVID and other sort of chronic fatigue, where if they push it too much, it seems to actually make it worse. So there's this very delicate balance for them of needing to continue to exercise and keep their strength, but not kind of overdoing it because they do tend to deteriorate. So they have that incredible support. And I met people actually who were there, they went swimming every day. They would go multiple times a week and work with physical therapists. We, of course, don't have anything quite that organized here. There is certainly a massive network of post-polio syndrome groups where they try to support each other, provide recommendations. One thing they really struggle with is finding doctors to even go to who will even acknowledge that post-polio syndrome exists, because it's what's called a diagnosis of exclusion, meaning there's no test for it. So people, kind of struggle, and because it's these non-specific symptoms that they sort of get passed off as, oh, you're just fatigued. Well, that's normal aging, but it's not, right, for them. So over here, it is more hodgepodge of support, where some people are able to get a really nice, good level of things like physical therapy, but others really struggle to get the necessary support they need. We're actually we just put in an NIH grant, which, may or may not exist in the future. To look at post-polio syndrome in anesthesia, because it's one of their big concerns.
And just out of curiosity, How many doctors do you know that have seen a case of polio?
Almost none. I try to think if anyone I've talked to has seen a case of polio, and I think maybe one in England who, kind of an old timer. Certainly, and that's acute polio, meaning kind of new onset. Certainly I do know people who've taken, and in fact, I've taken care of post-polio syndrome patients. But yes, and I, would often say, I hope to God we never see a case of polio, in our ICUs here in New York or anywhere, because it would just be beyond devastating to see that happen and to make that diagnosis. It would break my heart. In COVID, it was really hard to take care of patients who were dying who hadn't gotten the vaccine. And it really did a number on a lot of us emotionally, mentally, when we knew that probably with the vaccine, they might still have been quite ill, but the chance of death would have gone down dramatically. And there's a sort of special, corner of hell for trying to support someone through something that feels preventable. And so that's why, I'm definitely on the road as much as possible, trying to advocate for
And
vaccination.
it's equally unconscionable that a child should die of measles in the United States.
Absolutely, yes.
This should be an easy answer. I got my vaccine in 1955. I remember vividly, but when was that double-blind study for 1 million children?
1954. Now, it took, you have to realize this was an era before computers. So you had over 1 million kids taking 3 shots each and then observed controls. This all had to be done by hand. So it took a full year to decide how effective this vaccine came out. And when the word came down at a very famous press conference that the vaccine was safe, potent, and effective, America had a national day of celebration. It was unbelievable. President Eisenhower invited Jonas Salk to the White House, and with tears in his eyes, no one had seen ICLID like this. I thanked Jonas Salk for saving the children of the world. If you want to talk the high point of medicine, that was it.
I found out only after my family members read my book. One of my uncles emailed me and said, I was in the trial. And they were called polio pioneers. They got stickers, and I had no idea the entire time I was writing the book. So yes, but it was really remarkable. And there's an amazing photo of the room where they stored all of the data. This is in Michigan for the trial. And I looked at that room as someone who does large database analyses and works a lot with data on computers, and just my head exploded at the idea of having to tally by hand all of the data points for that study. It's really extraordinary what they accomplished.
So I wanted to ask Hannah, why do you think it was that the discovery of the positive pressure device had to come from this guy in Denmark instead of one of the guys in Boston?
Yeah, it's one of those things where, so positive pressure ventilation did exist. It existed in some operating rooms in Sweden, in the United States, and in the UK. But they were very scattered, kind of small places that did this. And the big leap was this idea that you could take this thing that was being used during anesthesia and use it on someone outside of the operating room who was having trouble breathing for another reason. And it is one of those things that I struggle with, like, how could they not have figured this out earlier, right? It just seems so obvious. And there had been a lot of experimentation over the years, 19th century, there's all kinds of people trying stuff. It's this weird confluence of, just kind of the right time, the right place. And I think also the fact that they had hundreds of patients to demonstrate it on all at once with this polio epidemic, that made it a very compelling, convincing story. And then on top of that, Henry Lassen, who was the head of the hospital, was a really good self-advocate for what they had accomplished. So he publishes very quickly a paper where he's the sole author, describing what they have done at the Blindham Hospital, showing that the mortality has dropped from 90% to, almost 10%. And so you also need, someone like that. And later, when the first ICUs that get established in the United States are 1958, a number of years later, one of the memoirs by one of the doctors who established the first ICU in Baltimore said, we knew what they'd done at the Blindham. So he was very aware because of this ability to, provide that information. So, we'll never know for sure why it didn't happen sooner. I often speculate, that Ibsen had the chance to show on one patient that this was effective, and she was very sick. She was very close to death. And he did get lucky that she didn't die on him, because she was so close to death. And you sort of speculate, well, what would have happened if she died? And I don't think someone else would have ultimately figured out positive pressure ventilation outside the operating room, but it would have been delayed, clearly. And it is hard in hindsight to understand how they could have kind of been so blind in a way to this concept, but that was the reality.
Is there any recommendation that those of us who had the vaccine back in the 50s should revaccinate?
That's a tricky question. I would say that, you obviously should talk to your personal physician about that. But if you were given the polio vaccine, either the Sabin oral or 3 shots of the Salk vaccine, I think you're in very good shape. Right now, as Hannah knows, there's a different schedule for children to take the polio vaccine, but I am unaware of a case where someone who was fully vaccinated got polio. So I would say, unlike measles, mumps, stuff like that, we're talking about a different situation here.
Yeah, I have seen some advisories for people actually around my generation, sort of late 60s through the 70s, that if you don't have titers or you're going to an area with a higher risk, that you might want to talk with your doctor about whether or not to get a booster. But I think particularly the people who had the Sabin vaccine, the oral vaccine, that is actually considered a stronger defense. The injections, there's a little bit more uncertainty around if you only got that, whether or not it provides absolutely full immunity for an entire lifetime. But to David's point, I don't think there's been any case.
Yeah. And I will just add that we have gone back. We in the United States, we started with the Salk, moved over to the Sabin, but we've gone back to a juiced up version of the Salk inactivated vaccine, because in an infinitesimally small number of cases, the live virus vaccine can revert to virulence. And the numbers are astonishingly small, but I think it's like 1 in 750,000 cases. It is possible, to get polio from the vaccine, or if you're unvaccinated and you've been close to a person who has just been vaccinated, that is a possibility.
Yeah, the vaccines for polio are quite complicated, actually. It's not, it's not a straightforward story of the different vaccines and the risks and benefits of them. I mean, clearly the benefits far outweigh any risks with either vaccine.
Exactly.
But when you get into the nuances, and it is
right now in the West, we just use the inactivated Salk vaccine. But in countries like Pakistan, where it's very hard to give injections to send people out, it's just so much easier and cheaper to use the Sabin vaccine. They do use that vaccine. And I guess the end game, Hannah, is that when you get the numbers almost down to 0, then the Salk vaccine will be the vaccine that they would use after that.
We could have a whole talk just on
Yes.
vaccine strategies.
Yeah.
What about the kids who didn't get the polio vaccine? In the experiment.
Oh, so they went back and were vaccinated the
Yes,
next year.
they
Yes.
were first on the list, but you've raised a very interesting question. Early on, Jonas Salk was opposed to this study. He said, look, I know my vaccine works and I think it's unconscionable in the middle of polio season to give half these kids a placebo. But much of times wanted to pass scientific muster, and this was the way it was done. So there were moral questions that were raised at the time about giving placebos, but Hannah's absolutely right. The deal was that if you got a placebo, you were first in line the next year to get the real vaccine.
Is there any pushback against the polio vaccine like there was for, say, COVID? As someone who obviously didn't live through polio, it's very
Yeah, I mean, it's
hard
to me,
that
yeah.
people wouldn't just push back against it.
What's remarkable, I mean, there was even a disaster with the polio vaccine, it was called the Cutter incident. And right after it came out, a number of different companies were given the right to make the vaccine, and one of them did not follow the instructions to the letter. And they did not fully kill the vaccine, the virus in one of the batches. And it actually was given, and there were about 20 deaths and a couple hundred people paralyzed from it before they figured out what had happened. And despite that, we got to herd immunity in this country within a few years.
Yeah, it was
So,
quite, yeah.
It's really remarkable.
It is. You have to understand that when the Salk vaccine is determined to be safe, potent, and effective, every parent in the country wants that vaccine immediately. So what, as Hannah mentioned, what happened is that the government gave 5 or 6 companies the recipe. Actually, Salk gave it to them, but there was very little oversight. And it wasn't just Cutter, other companies were having similar problems. The problem was that Cutter was very quiet about the problems that had arisen. And what they did was, if there's a bad batch, they just threw it out. Without telling anyone that, they had done this. So they were on the West Coast, they were from Berkeley, California. And suddenly you start seeing kids in California, Washington, Oregon, coming down with full-blown paralytic polio after taking the Cutter vaccine. It was probably the worst incident in our history involving vaccines. But as Hannah mentions, Americans were so keyed up about vaccination at this time that as soon as, they stopped all vaccines for a short period of time, all polio vaccines. As soon as they were given the green light, parents lined up their kids again.
But, so it was very different, very, very different culture and feeling. And, it reflected the fact that polio and the sequelae, the consequence of polio really were all around everybody. You could see it, the kids in your class who came back with crutches or in a wheelchair, or somebody who just never came back, that I think that really overrode any concerns. Exactly. And there was just much more confidence in the government and medical community at that time.
Yeah, I can remember going back to school as in the 3rd, 4th, 5th grade, before, actually even a little younger, before the vaccine. And every September, you see a kid in a wheelchair, you see kids in leg braces, and you see the occasional empty chair where the kid hadn't made it through the summer. This is what parents dealt with. And as we mentioned, it was risk versus reward. And the reward was a safe and happy child.
1 or 2 more questions?
Sure.
I'll get you next.
The polio virus is alive in the world, in these places, Ethiopia, Nigeria, Afghanistan, Pakistan. Is there smallpox virus still extant? And is it a good idea to eradicate it entirely, because then we could never study it?
That I can start with that, and you will certainly finish it off. There is no circulating smallpox virus in the world. So there's no way you could get it unless North Korea gets it. Or the United States and the Soviet Union were given the smallpox virus. They did not have to destroy it. They were allowed to, keep samples just in case. But it's, the question you raise is when you just wipe something off the face of the earth completely, are there problems that may arise? Give you an example. Hannah, you probably know that Duke University is working with polio virus now to stop certain types of brain cancers. It's amazing. Smallpox is a different animal in the fact that it can be weaponized in ways that polio virus cannot. If what I mean by that is if you were to let polio virus out in this room, it wouldn't, maybe 1 in 100.
You won't kill everybody off.
You're not going to kill anybody. You really, with smallpox, oh my God, if you were to let smallpox out in the subway, you'd have a real problem on your hands. And by far in terms of say measles, that may be among the most infectious diseases in the world. Polio is not. Polio is contagious. You can get it, but the numbers were always, in terms of other diseases, relatively modest. What made polio so different was that it was a children's disease and it was a visual disease. You go into a restaurant, you don't know who has a heart condition, but you know who has polio.
But I also think that in talking about kind of eradicating diseases, we have a lot of diseases that are actually quite rare, right? So we don't sort of lament that they're not more common because it would be easier to study them. We do in the research community, but of course, that's not something we actively want. So I think, the goal, of course, is just to reach the point where we don't need to study it. Because it is eradicated. And it is a real challenge with diseases. There's a lot of them out there that aren't very common, and it becomes a real challenge to get enough numbers to do any meaningful research on them.
Yeah. But eradicating something entirely can have unforeseen consequences. So it's a very good point you made.
Did the fear of polio drive people to the suburbs?
This is the uncle who was not part of the trial.
My parents were school teachers, didn't have much money. We went to the Adirondacks every summer. I'd say part of that was to get us out of the city because of polio. And part of it was that beaches were closed, movie theaters and bowling alleys. Kids had to social distance when they're certainly in their own neighborhoods. So it's an interesting question. I'd say it's probably secondary, but yes.
And then, I think we also have to think about things like TB, right, as being drivers of getting people out of at least very crowded conditions, as being a disease that certainly a little bit prior to polio was probably a big driver of people trying to get out of tenements and places like that. So not just polio. Oh, one last question.
Isn't it true that most cases of polio was relatively mild, that only a small percentage resulted in paralysis?
Yes, that is correct. And in fact, most are asymptomatic. So it's actually a lot like COVID in that many people get it, never know they had it. It doesn't do anything to you. And then some percentage got sort of cold-like symptoms, kind of general flu, childhood illness symptoms. And then it was a very small percentage. And it seemed to vary with the strain of polio, because there were different strains out there as to what the virulence was, kind of how often it caused paralysis. But again, there was never any rhyme or reason to kind of predicting who would get the paralysis. And I think that's part of what made it so terrifying, was that unpredictability and our lack of understanding of who was truly at risk for developing paralysis.
Yeah, it made it much more difficult to contain because there were so many silent carriers. When you have smallpox, everybody knows almost immediately that you have smallpox, and they can use surveillance and containment. With polio and with COVID, you couldn't do that.
Thank you so much.
On that cheery note.
Fascinating note. This has been wonderful, incredible. Thank you so much, Dr. Johnson. Thank you.
Thank you. It was great.